Welcome to Quest for Wellbeing. In this Part 2 video, we continue our exploration of blood transfusion and its safety. Join us now as we delve into some very insightful aspects of the quality alternatives to transfusion. Is it possible to find any high-quality alternatives? Well, that's a great question, and it's important to emphasize the word quality. As reported in the Journal of the American Medical Association, July 1, 1988, Dr. Grant E. Stephan highlighted two important aspects. He noted that quality medical care is the ability of its components to meet both legitimate medical and non-medical objectives. Non-medical objectives would include respecting the patient's ethical beliefs or their conscience guided by biblical principles. But are there valid and effective methods for managing severe medical conditions without relying on blood? Fortunately, the answer is a resounding yes. While most surgeons had previously claimed they used blood only when absolutely necessary, their blood use decreased significantly with the advent of the AIDS epidemic. An editorial in the September 1988 issue of Mayo Clinic Proceedings noted that one positive outcome of the epidemic was the adoption of new strategies by both patients and doctors to avoid blood transfusions. According to a blood bank official, the shift has been due to increased awareness of risks, greater receptivity among clinicians to the message, and a higher demand for alternative options, as reported in the October 1989 issue of Transfusion Medicine Reviews. It's important to note that there are indeed alternatives. However, this will become clearer when we examine the reasons behind blood transfusions. We know that hemoglobin within red blood cells is responsible for carrying the oxygen essential for maintaining health and sustaining life. Therefore, if a person has experienced significant blood loss, it might seem logical to replenish it. Typically, blood contains about 14 to 15 grams of hemoglobin per 100 cubic centimeters. Another way to measure this concentration is by hematocrit, which is usually around 45%. The conventional guideline has been to administer a blood transfusion before surgery if a patient's hemoglobin level falls below 10 grams per deciliter or 30% hematocrit. According to a report in the Swiss journal Vox Sanguinis, March 1987, 65% of anesthesiologists required patients to have a preoperative hemoglobin level of 10 grams per deciliter for elective surgeries. At a 1988 conference on blood transfusion, Professor Howard L. Zauder posed this question: how did we get a magic number? He unequivocally stated that the origin of the rule that a patient must have 10 grams of hemoglobin, HGB, before receiving anesthesia is rooted in tradition, enveloped in obscurity, and lacks clinical or experimental validation. Now, consider the countless patients whose transfusions were prompted by this obscure and unsubstantiated requirement. Some may question why a hemoglobin level of 14 is considered normal when you can manage with significantly lower levels. The reason is that this provides you with a substantial reserve of oxygen-carrying capacity, ensuring you're prepared for exercise or strenuous activity. Research on anemic patients has shown that it's challenging to notice a decrease in work capacity even with hemoglobin levels as low as 7 grams per deciliter. Other studies have found only moderate impairment in function at such levels, according to Contemporary Transfusion Practice, 1987. While adults can manage with low hemoglobin levels, what about children? Well, as reported in Pediatric Clinics of North America in February 1986, Dr. James A. Stockman III notes that most premature infants will see a drop in hemoglobin within the first 1 to 3 months after birth. However, the guidelines for transfusions in newborns are not clearly established. Surprisingly, many infants appear to handle significantly low hemoglobin levels without showing any noticeable clinical issues, as reported in Pediatric Clinics of North America in February 1986. Now, this information does not imply that no action is required if someone experiences significant blood loss due to an accident or surgery. In cases of rapid and substantial blood loss, the individual's blood pressure can drop, potentially leading to shock. The immediate priority is to stop the bleeding and restore the blood volume in their system. This will help prevent shock and maintain circulation of the remaining red blood cells and other components. According to Blood Transfusion Therapy, A Physician's Handbook, 1989, volume replacement can be achieved without resorting to whole blood or blood plasma by using various non-blood fluids that act as effective volume expanders. The most basic option is saline, salt solution, which is both cost-effective and compatible with human blood. Other fluids with unique properties include dextrin, Hemaxel, and lactated Ringer's solution. Hedastark, HES, is a more recent volume expander that is recommended for burn patients who prefer to avoid blood products, according to Journal of Burn Care and Rehabilitation, January-February 1989. These fluids offer distinct benefits. Crystalloids, such as normal saline and lactated Ringer's solution, as well as dextrin and HES, are relatively non-toxic, inexpensive, easily accessible, can be stored at room temperature, require no compatibility testing, and do not carry the risk of transfusion-transmitted diseases. You might wonder why non-blood replacement fluids are effective, given that red blood cells are essential for transporting oxygen throughout your body. However, as previously noted, your body has oxygen-carrying reserves. When you lose blood, your body activates remarkable compensatory mechanisms. Your heart increases its output with each beat. Because the lost blood is replaced with an appropriate fluid, the now thinner blood flows more easily through even the smallest vessels. Chemical changes further enhance oxygen release to the tissues. These adaptations are so efficient that with only half of your red blood cells remaining, oxygen delivery can still be around 75% of normal. At rest, a person uses only about 25% of the oxygen available in their blood, and general anesthetics further lower the body's oxygen demands. Skilled physicians can assist those who have lost blood and have a reduced number of red cells. After restoring blood volume, doctors can administer oxygen at high concentrations, which increases its availability to the body and has often produced remarkable results. British doctors successfully used this approach on a woman whose hemoglobin level dropped to 1.8 grams per deciliter due to severe blood loss. She was treated with high concentrations of inspired oxygen and transfusions of large volumes of gelatin solution, Hemaxel, as reported in Anesthesia, January 1987. The report also notes that others with acute blood loss have been successfully treated in hyperbaric oxygen chambers. Doctors can also assist their patients in producing more red blood cells by administering iron-containing supplements either through muscle injections or intravenously. These treatments can accelerate red blood cell production by 3 to 4 times the normal rate. Recently, an additional option has become available. The kidneys naturally produce a hormone called erythropoietin, or EPO, which prompts the bone marrow to generate red blood cells. Now, synthetic recombinant EPO is accessible, allowing physicians to administer it to certain anemic patients, enabling them to rapidly produce replacement red blood cells. Even during surgery, proficient and diligent surgeons and anesthesiologists can assist by utilizing advanced blood conservation techniques. The importance of precise surgical methods, such as using electrocautery to reduce bleeding, cannot be overstated. In some cases, blood that flows into a wound can be aspirated, filtered, and reinfused back into the patient's circulation. Patients who undergo heart-lung machine procedures that use a non-blood fluid for priming may experience benefits from the resulting hemodilution, including a reduction in red blood cell loss. There are various methods to assist in reducing the need for blood transfusions. These include cooling a patient to lower oxygen requirements during surgery, using hypotensive anesthesia, and employing therapies to enhance coagulation. Additionally, desmopressin, or DDAVP, can be used to reduce bleeding time, and laser scalpels offer precise cutting with minimal blood loss. As both physicians and patients increasingly aim to avoid blood transfusions, the list of alternatives continues to expand. While we hope you never experience significant blood loss, if it were to happen, skilled doctors could likely manage your care without resorting to blood transfusions, which carry numerous risks. Many individuals today refuse blood for health reasons, similar to the preference for alternative non-blood management that is primarily sought by witnesses for religious reasons. As was observed earlier, major surgery remains feasible. If you have any remaining doubts, additional evidence from medical literature may help to address them. The article "Quadruple Major Joint Replacement in Members of Jehovah's Witnesses in Orthopedic Review," August 1986, described a patient suffering from anemia and severe joint damage in both knees and hips. Iron dextrin was administered before and after the staged surgery, which proved successful. The British Journal of Anesthesia, 1982, detailed the case of a 52-year-old Jehovah's Witness with a hemoglobin level below 10, who underwent total hip and shoulder replacements using hypotensive anesthesia to reduce blood loss. Similarly, a surgical team at the University of Arkansas conducted 100 hip replacements on Jehovah's Witness patients using this technique, with all patients recovering well. The department head noted that what they have learned from those witness patients, they now apply it to all their patients that they perform total hips on. It's important to note that there are some Jehovah's Witnesses whose consciences allow them to accept organ transplants as long as no blood is involved. A study on 13 kidney transplants found that the overall results suggest that renal transplantation can be safely and effectively applied to most Jehovah's Witnesses according to Transplantation, June 1988. Similarly, the refusal of blood has not prevented the success of heart transplants. What about other types of bloodless surgery, you might ask? Well, according to Medical Hotline, April-May 1983, there were cases of Jehovah's Witnesses undergoing major gynecological and obstetric surgeries at Wayne State University, USA, without blood transfusions. The newsletter noted that these surgeries had no higher rates of death or complications compared to women who received blood transfusions. The newsletter concluded by suggesting that the findings of this study might prompt a reevaluation of blood use in all obstetric and gynecological procedures. At Göttingen University Hospital in Germany, 30 patients who refused blood transfusions underwent general surgery. There were no complications that wouldn't have also been possible in patients who accepted blood transfusions. The absence of transfusions shouldn't be overemphasized to the point of avoiding a necessary and surgically justified operation, as published in the book Risiko in der Chirurgie, 1987. At New York University Medical Center, brain surgeries have been successfully performed without the use of blood on many adults and children. For example, in 1989, Dr. Joseph Ransohoff, the head of neurosurgery, wrote that in most cases, blood products can be avoided with minimal risk, especially if the surgery is performed quickly and efficiently, catering to patients with religious beliefs against the use of blood. He also noted that he often forgets a patient is a witness until they express their gratitude for respecting their religious convictions at discharge. As published in the book Herz-Kreislauf, August 1987, Professor Dr. V. Schlosser from the Surgical Hospital at the University of Freiburg in Germany observed that in patients who are Jehovah's Witnesses, there was no increase in the incidence of bleeding during the perioperative period. In fact, he noted that complications were fewer. He further stated that the unique perspective on illness, characteristic of Jehovah's Witnesses, positively impacted the perioperative process. In conclusion, as research continues to advance, these alternatives may not only reduce the risks associated with traditional transfusions, but also provide patients with more tailored and effective solutions. Embracing these innovations is essential in moving towards a future where patient safety and treatment efficacy are maximized. Did you find this quest insightful? Well, if the answer is yes, please let us know by commenting in the comment section below. And please remember to like, share, and subscribe to our channel for more insightful videos. Cheers to an enriched life. Thank you for watching.